So, good evening, friends. So, today is a very eventful day for me. It's been a journey of 5 years since I started this YouTube videos. So, today is 1st May 2025, and this is the 500th video, friends. So, this is something which has been an incredible journey. And here, before I start the narrative on what's going to the future of ICU, so wish to place on record my sincere gratitude and thanks to all the subscribers, viewers who have been part of this incredible journey. And special thanks to each and every one of my trainee who has been instrumental in the formulation and formation of these videos and the insights, feedback, and quiet encouragement that has been given by all the viewers over the years has been the quintessence in doing these videos. And my sincere thanks for all the people who have been part of this journey. And the whole journey started 5 years back in the thick of COVID, friends. And that is where I felt there was an intense desire to put forth a good evidence-based narrative on the practice of critical care so that there is some sort of a homogeneity that prevails in the practice of intensive care. As I could see, there was a lot of variation in the conceptual understanding of intensive care. And this has led to this 500th video. And I'm so delighted to say there have been 8,50,000 views so far and 65,400 hours of viewing. So 65,400 hours of viewing. And there have been close to 15,000 subscribers at this point of time as I'm speaking. So the run rate, if you ask me, has been 100 videos per year, about 3 a week. So that is the sort. So I wish to maybe put a next sort of a goal, which I would think would be 1,000 videos. Maybe that would possibly, with God's grace, see, would happen possibly in much less than 5 years. So my sincere thanks to my mentor and teacher, Sriram Sampath, who always remains my guru. And I wish to thank Almighty Lord Sri Krishna, who, without whose blessings this wouldn't have been possible, friends. So I thought very carefully as to what should be the 500th video, and I felt what is in store for future in ICU in the next 5 years. I wouldn't want to really speak on what would be the future of ICU maybe in 10 years because we don't know what's going to happen. But at least in 5 years, what's going to be the future? I thought this is something that would be insightful for me as well and for all my friends who would be listening to this. And it would be meaningful that we gear up for what changes are going to happen in next 5 years. And as you know, friends, I've been doing a little bit of a series on AI, how AI is going to transform. In fact, I had a very critical sort of a feedback on one of the AI in sepsis when I put out on a YouTube. A very close friend of mine, actually, is a very senior physician. He said, Pradeep sir, what are you talking on having robots in ICU and AI? Nothing can replace physicians. Yeah, I absolutely agree. Nothing can replace, but we have to embrace the AI, which is going to be a part and parcel of our care delivery. And robots, he said, you are talking about robots. I didn't even speak about robots in sepsis, but robots are in the pipeline. And we would very soon have humanoids and robotics helping us in the care of these patients. And we are already seeing robotics in surgery. So, so whatever I'm putting forth is from the science. It's not my belief system. It's from the evidence that has been evolving, and it's the published data that I'm speaking about, friends. So let's jump into this future of ICU. What's in store for us in next 5 years? So AI remains the buzzword, and AI is going to make phenomenal change in the way we practice intensive care. And we have been seeing this, and I've done series of AI in respiratory, AI in sepsis, and I would be doing AI in acute kidney injury, so on and so forth. So AI is an adjunct which helps us to make good decision making. And the real-time predictive analysis is something AI will help us in. You tell me, my friends, would we be able to do real-time hour-to-hour assessment of a patient? It's almost impossible. We may do rounds 2 to 3 times, and nurses are charting it, but would you be doing real-time predictive analysis? No. So what are we doing in ICU? I tell every trainee who comes to me, the first thing I tell is ICU is all about integrating information. What all information we integrate? we integrate clinical examination findings, history, and all the nice clinical science and the clinical acumen you apply. And we capture all the gadgets patient is connected to, be it ventilator, be it infusion pumps, be it dialysis machine, be it ECMO machine, so on and so forth. And then we integrate the vitals from coming from the monitor. And we integrate all the laboratory data and the imaging. So this is all we are doing every day in the rounds. We are integrating clinical information, monitored variables, and investigative modalities and all the equipments that patient is connected to you in hour to hour basis. We are integrating and making plans as to the diagnostic plans and therapeutic plans. So this integration is what exactly AI will be doing. And what it helps us do is reduces our cognitive burden, because we have to apply our mind every time we keep integrating these elements. So AI is only going to help us and act as an adjunct in reducing our cognitive burden and help us to attain good diagnostic sort of realms, and help us to optimize our treatment. And it can also possibly give us recommendations as to what is the right sort of a clinical pathway that we need to adopt. So this is what we are looking at. And machine learning tools, if you're saying that, yeah, AI is not here, it's already here. It's already, we have AI algorithms being incorporated in ventilators, and machine learning tools is already put in place. There is an endo tool that is come, which is a machine learning based optimization of glycemic control. So it already endo tool is in the market, which optimizes your insulin dosing and helps you to manage glucose control in the most optimal way. And this has shown, endo tool has shown to reduce your nursing workload and metabolic care workload by 20%, friends. So already the tools are here. And AI in ICU, I have done a series of video on respiratory. So there are already algorithms, TriVean, Vean mechanical ventilation. Better Care is a software algorithm that's already incorporated to minimize your dysynchrony that prevails from breath-to-breath analysis. So breath-to-breath analysis humanly is not possible. TriVean and Vean mechanical is a predictive sort of an algorithms to see and determine the right timing for extubation, and they have shown very good accuracy, and I've done a videos on that. And there are algorithms which are assessing breath-to-breath flow rate and airway pressure to calculate resistance and compliance with every breath, and accuracy has been phenomenal at 99%, friends. So there's already algorithms being put in place in the ventilator, and this is only going to synchronize our breaths much better. And I've always said that possibly in times to come, we wouldn't have mechanical ventilation workshop, because all these algorithms take care of all the dysynchrony and all the airway pressure, flow rates, optimization, resistance, compliance optimization, PEEP optimization, all that is already happening. And adaptive support ventilation already has AI algorithms embedded, where you only have to put the weight of the patient and the age and so on and so forth, and it does everything. So it's already there. And AI in sepsis, I have given a little narrative snippet video on this. So artificial intelligence, sepsis expert, and long short-term memory algorithms, sepsis evaluation and risk assessment, SERA algorithm. These algorithms are already put in place to try and identify the patients much before clinically evident sepsis get manifest. And there was a criticism for this in my YouTube, saying, how can all this happen? Yes, it's happening, and these are published data. And if you have to criticize, we need to do our own studies and prove they are wrong. They've already shown good accuracy in able to pick up sepsis 2 hours before, even up to 20 hours. So that was a criticism that I came. How can one? Yeah, you can, because these algorithms have that ability, because they take around 206 variables and try to integrate and try to put out your prediction based on large data sets that they have collated. And what about artificial intelligence in kidney? So artificial intelligence, um, so random forest has been used to look at and predict the risk of contrast-induced nephropathy. And there is an algorithm put up by Tomasev algorithm, which has AI algorithm, which has an ability to do good AKI prediction up to 80%. So which I will show you in detail. So I'll do a snippet on AI in kidney. So these are already algorithms are there. So random forest AI algorithms to predict contrast-induced nephropathy, Tomasev AI algorithms to predict AKI. And then there are wearable dialysis, which have AI algorithms put in place. And then there are bionic kidneys, which is already being developed. And you may have bionic kidneys put in place with AI algorithms incorporated into them. So this is the technology that is advancing in AI. Cardiovascular, don't even ask me. There are so many AI sort of algorithms. So the first one is AI clinical decision support systems in coronary heart disease. So trying to predict which are the patients who are at a risk of developing coronary artery disease. There is a heart model algorithms which tries to capture all the echo indices and tries to give you a analytical sort of a interpretation of what the findings are. And there is AI algorithms for ECG interpretation to predict the risk of cardiovascular events and the systolic dysfunction. And there is deep learning genomics trying to predict the patients who are at a risk from the genetic standpoints of coronary artery disease. This is interesting. VLAB is a very interesting concept which is already there, where there is a continuous assessment of left atrial pressure to optimize heart failure patients. Then there is OASIS, which is already in place. OASIS algorithms, outcome and assessment influencing set, which predicts the risk of hospitalization of patients with cardiovascular disease. So it predicts the patients who are at a risk of hospitalization, who have the underlying coronary artery disease or heart failure. So there are so many algorithms. So I'll make separate video on AI in cardiovascular disease, AI in kidney, which I have not done, and there is AI in trauma, there is AI in nutrition, AI to predict delirium. So there are algorithms put in place based on all the large data from the medical information mart and other big databases, trying to create algorithms which predicts which are the patients who are at a risk of these conditions. Is already in market, friends. Is already in place. So we wouldn't be long when we start using these algorithms in a routine sort of a way. And so we'll move from AI. The big buzz is Tele-ICU and tele-rounds. I mean, the one disillusionment or a grief for me is I was so much a part of Tele-ICU and tele-rounds in the thick of COVID, and we showcased how many lives it can save. But the sort of disillusionment is none of the new hospitals that are coming out in a big way are adopting. So this is the future, friends. This is the science telling us that tele-ICU or tele-digital ICU is the way forward. And I don't see the new age hospitals embracing this or putting it in a visionary way on this digital health. I think for some reason, strange reasons, all the big hospitals are coming with all the fancy gadgets, but somehow we are not seeing the digital command centers being. This I had envisaged 5 years back in the thick of COVID. Government is sort of doing it, but somewhere it lost its way. I wish I'm in some sort of a decision making where this is the norm. I mean, I don't know why none of the private hospitals are putting their wherewithal in setting up digital command. And this science is telling us worldwide. I'll show you the type of budgeting that they're looking at. The compound annual growth rate of digital health worldwide is put at 15%. And none of the new hospitals that are coming in Bangalore or any big city are adopting this digital health or tele-ICU. It really saddens me as to why this is not happening. And I'm in no position to convince any of the health leaders as to why they're not putting their mind into this tele-ICU concept. And there are some sort of a fragmented players in this segment. There are good players, of course, but it is sort of a very disorganized sector at this point of time. So how does this help? So this helps in analytics. This helps in putting all your AI algorithms in place. The way it works is there needs to be a digital command center, friends, where you collect all the data is transferred from ICUs and even from the hospital beds and even ICU at home. It's a huge sector we are looking at where all this information is fed. And there is one command center like a war room with all the monitors where people are looking at it and trying to make sense of all the data that is flowing from ICU, from the home and from the wards, and trying to take preemptive steps in preventing sentinel event in these patients and optimizing the care. And instructions are given to these sort of centers where they are being monitored to optimize the care. And this is not happening anywhere, which saddens me. And even all this data can be even remote. And now the technology is become quite affordable. It is not very humongously expensive because I have looked into the numbers with regards to the costing involved. It is coming at a pittance. Technology is coming at a pittance, but the whole vision of putting this in place in the new healthcare giants that are coming is not happening, which is really saddening me. So I don't know why this is not happening. See, look at this, friends. Look at this. 2025, the Tele-ICU business is 6.27 billion. And the projected in 2030, I'm only looking 5 years from now, is 12.46 billion. 14.5% compound annual growth rate it's going to increase, and we are not capturing. None of the hospitals in India, I think, have put their mind into this Tele-ICU or digital health for that matter. When I say Tele-ICU, you need to have a digital command center which is taking control of all the digital inputs that are coming from advanced monitoring system, be it ICU, HDU, OT, or home care. Some patients who may have digitally variables, they all need to be relayed there, and there is a team sitting there constantly monitoring, acting upon it, and optimizing. This is the way forward, friends. And it comes at a pittance. We have done the cost evaluation. All the data from the ventilator, infusion pumps, monitor can be sort of integrated by IoT connectors, which are data connectors, goes to a central server and goes to a command center. It's not at all difficult. The investment for the brick and mortar, people are putting millions of rupees or billions of rupees, but this is such a simple technology which is coming at a very low cost, but there is no sort of a wherewithal put into this. So this is the model. It's very easy. I would plead every healthcare organization that they should have command center. I mean, I say command center, it's not to do business with other smaller nursing homes. It's to do business between your own hospitals or within the areas in your hospital. I think that is what we are looking at. And this will ensure absolute sort of a enhanced outcomes to our patients in the hospitals. And you would show a remarkable benefit to the patients. And they do analytics. All the sort of algorithms that we are talking about can be embedded into this. And how do you apply algorithms when you do not have digital command center? So all analytics the machines do. You don't have to sit and do. Machines will do and will be putting forth the sort of suggestions or the decision trees for you. And how beautiful is that? And device connectivity is only helping you. What AI does? What is AI doing? Integration of clinical, monitored, investigative modalities to help diagnosis and treat. This is what your digital health command centers would be helping you to do. Use audiovisual cues, do analytics, and use AI to do algorithms. And this is the future that we really need to look at, which I don't think any hospital in India who are expanding at a mammoth scale are not looking at this. So it's very saddens me. So I do not know what the solution is. But I have narrated, resonated this idea to anyone and everyone who I have met in the healthcare leadership, but somehow this doesn't look like it's taking off in any sort of a reasonable. And this is the model we are looking at, friends. Every hospital chains need to be interconnected. And this interconnection can expand to even ambulance care centers from the time they pick up the patient. How beautiful it is that a patient gets picked up and the digital command center is optimizing the care whilst the patient is in ambulance. How beautiful is this, friends? And this comes at such a low cost. And I don't think there has been a visionary who can do this, very unfortunately. And all this, I'm sure you're all aware. So this is how we have to look at the future. Okay, let's go into interoperability. So I spoke about AI, then we spoke about Tele-ICU, which none of the big hospitals, healthcare chains have taken up. And we need to have best practice guidelines put in place. And the only way best practice guidelines can be imparted, which we showed in COVID, is through interoperability and integrating all the healthcare services in the hospitals that are connected to each other, friends. And this improves regional coordination, and even manpower optimization can be very well done with this sort of an integration. And capacity crisis is something that can be attained by having good sort of an integrative platform where all the data could be sort of looked at in a, see, in COVID, friends, I think we had in Karnataka, I don't know about other states, we had a war room. And in war room, what is war room? War room is exactly the digital command center where we were trying to interpret what is the sort of a nursing deficiency that is there, what is the sort of a capacity building that needs to be done in some places. And this was all done by bureaucrats. I don't know, as medical fraternity, we have failed miserably in trying to do this, try to integrate, try to optimize our resources, try to optimize our manpower, try to optimize our best practice guidelines. We have failed miserably as a healthcare leaders who have the ability to sort of execute this. Somehow we have not been able to do this. And robotics. So I was criticized saying, what are you, Pradeep sir? You are telling all about AI and robotics, and we have to look at improving our physician care. Yes, robotics are already there, friends. And surgery, there is already robotics that are in place, which is using high precision sort of a surgery. And look at this. So this is the visuals where robotics, where I went to China last year and I saw robots present in every hotel, and they do the work of a human in doing room service. And we had a robot in COVID also, where human entry into COVID zones was sort of little limited, and robots developed by Indian Institute of Science was trialed in our Bangalore Medical College Hospital. So this is on. I think India has really not taken it at a pace where other Asian countries are taken. China is very much ahead. Singapore is very much ahead of this robotics. South Korea is very much ahead. So it's in the offing, and we would very soon see this robotics helping us. And I say, look at this robotics trying to mobilize the patients. All these are in the offing, friends. So this is not very far away. So it is just in the takeoff, and this would take off in a big way. Robotics are here to stay, and robotics would be utilized to do face recognition, reduce the sort of a human manpower requirement, and even robotics may be used in the assessment of anxiety, delirium, and pain, friends. So this is where we are all heading, friends. And so we spoke about AI, which is obviously a big thing. We spoke about Tele-ICU, which is another big thing which we have ignored. And then robotics, India has not taken off in a big way. Now, precision critical care or precision medicine is a buzzword which everyone is talking about. What is precision medicine? Precision medicine is calibrating the healthcare to every individual based on their phenotype, based on their genotype. So we do genomics, we do biomarker sort of a profiling, and tailor the treatment of sepsis, ARDS, and all the ICU related treatment. So, and that has shown to improve the survival, friends. And that is something that will be very much, that is something which we're all working on. And now the blood draws, there would be effort to minimize the blood draws with ability to diagnose things more on inhalational stuff. So there may be technology which will soon be available where with inhalation, or with whatever, with breath analysis. Sorry, when I say breath analyzer to measure the lactate, breath analyzer to measure electrolytes, and breath analyzers to do the drug levels, because there are breath analyzers for alcohol. So do similarly breath analysis. So this is something that a lot of studies or basic science research is happening as to what all things can be measured with the breath analysis or non-blood drawing technique. So this is something that we would be very soon seeing. And then we'll move to the little more sort of administrative aspect, which is workforce and policy adaptations. So dynamic staffing models with the medical national guard. This is more at a public healthcare setups to optimize the manpower allocation or resource optimization by having this dynamic staffing model is something that has been advocated. And prioritizing resource allocation. This is more, applies more to the public systems where you need to have some sort of a distributive justice, the way we would prioritize certain resources and allocation of healthcare resources. And there's something called crisis standard of care, which tries to look at the contingency when there is a crisis, how to heighten our manpower allocation is something that has been advocated as a new norm, especially more applies to healthcare system and also in a large corporate health chains like ours. I think the best way to look at it is having a command center which oversees how manpower optimization is happening between the hospitals in a city. It can very easily be done. We did it in COVID. It's not at all difficult. And that is something I don't think many of them have put their mind into it. Okay, that's about, so we spoke about AI, then we spoke about tele-ICU, then we spoke about precision medicine, then we spoke about robotics, then we spoke about resource allocation and optimizing resources. And the last thing, last but not the least, is healthcare putting its effort into mental health of its health workers is found to be, this is not the last one. I will be talking about environmental also. That is the last, the green ICU. So the fifth one is paying attention to the mental health and retention of the staff. So having a sense of gratitude, appreciating the staff, exhibiting a transformational leadership in how you can retain the staff by appreciating them, having a sense of gratitude, mentoring them, and looking for some sort of an incentivization for the good work that is done, and taking care of their mental health goes a long way in preventing the attrition and retaining the staff, which is quintessential for effective running of the healthcare organization. So the last but not the least is the smart ICU environment. I'm sure everyone has been hearing about the smart. So the next 5 years, our whole effort is to reduce the carbon print in the ICU, which is also very important. So we have to move towards adhering and adopting the green ICU standards. So this is a whole lecture in itself, which I have not done. So I will possibly soon do a video on green ICU. So reducing the carbon print, which also is an adjunct or synergistic to resource allocation or resource optimization. And it would come to precision medicine also, because when you say precision medicine, that you would be catering or customizing or calibrating the healthcare to the needs of the patient. And the smart ICU also looks at noise optimization, how you keep the noise level at the bare minimum, automatic light adjustments and temperature control. All this go a long way in reducing the carbon footprint and creating more smart ICU. And this is also shown to improve patient recovery in a large way by minimizing the noise levels, minimize and good temperature control, light adjustments, and not unnecessarily using a lot of electricity when there's no need. All this has shown to reduce the carbon footprint, at the same time improve the patient recovery also. And we have seen scientifically how the automatic light adjustment, noise level reduction, all tend to reduce and mitigate your prevalence of delirium. So summarily, you can look at all this. So we're talking about big data. We're looking at IoT, which I mentioned, which is the IoT adapters, which basically integrate all the equipments and convert this digital data into some transferable data, which could be analyzed. And we have AI and robots. So the future of healthcare, very summarily, could be put into this capsule. So there will be a whole data which will be doing analytics, which will be suggesting to you as to the type of care pathways that you should adopt. And there is obviously this data is interlinked to technology. But if you see, the fulcrum of the whole healthcare is the patient, the fulcrum. So patient and the care we provide, the team, care team. So no one is telling that you will become obsolete. We become the integral part. So we remain at the center. So the care team, which is at the center, and shared education and clinical research. So all these four, friends, no one can eliminate. So the data, technology, and other aspects are only here to help us to provide optimal care to the patients with relentless pursuit in good education, homogenizing the care, and adopting the newer sort of a research findings into our practice. Following good ethical evidence-based medicine remains at the core of our healthcare delivery, which is all supported by data and technology, is the way we are looking at. So summing up, friends, 2030 ICU, we have to adopt AI and deep neural learning or deep learning, neural networks. All these jargons that we use is very much in place, and we will be driven by the algorithms to homogenize the healthcare. Tele-ICU, none of us have taken it up. None of the healthcare leaders have taken it up in a very systematic way, in a way that it has to be done with a good digital. Tell me one place which has a great digital command center, which has integrated all the digital inputs. I don't think anyone has done this yet in a very comprehensive way and shown how it can minimize the sort of a burden on the healthcare allocation, healthcare resources, and how it has improved the care. I don't think it has been comprehensively looked into. Robotics are very much, I think India has been a little slow in taking up robotics. This is very much in the pipeline. It will possibly revolutionize. And precision-based medicine or personalized medicine is the way, based on the genotyping of the patients, phenotyping of the patients, and looking at the genomic aspect of the patient and looking at the phenotype of the patient, looking at the biomarkers, which will determine the type of genotype, phenotype, is the way to go forward, friends. And resource optimization, because we are going to be burdened with the resource. And this makes sense even from the business point of view. You do a good human manpower optimization or resource optimization effectively in a comprehensive, integrative way. It does reek in a lot of revenue generation also and revenue optimization also. And last but not the least, reducing the carbon print is the way forward, and green ICU is here to stay. And we have to put in efforts to minimize the carbon footprint of our ICU. So that's about it, friends. So request you all to submit your valuable work to Journal of Acute Care, which is a beautiful journal, and you can publish all your nice little research work. Of course, you can keep visiting my website, Reher. So my next target would be at least 750, maybe in next 2 years. I would think I would be able to reach 750 or maybe more, and maybe 1,000 very soon, friends. And that will be my target. So thank you, friends. So I would end with this nice quote: knowledge is not power, it is only potential. Applying that knowledge is power. So we are still not applying that knowledge in an effective way as an intensive care community. If you look at where the future is, are we putting our energy into this? Sort of randomly we are doing, like random forest, but not in a very cohesive way. Maybe because not many intensivists are at the leadership position to advocate this change in the healthcare giants that are currently operating in India. Thank you, friends. Thank you. Thank you, one and all. And again, my sincere gratitude and thanks to all the people who have been following me. And without you, this journey would have never happened. And my salam and salutations to each one of you, friends. Thank you. Thank you, one and all.